All right, good morning, everybody. This is going to be my update on surviving sepsis guidelines. I think this needs to be updated on a regular basis, maybe every 6 months. So this is my job to update you on the latest, the 2017 Surviving Sepsis Guidelines that were just released by the Surviving Sepsis campaign and the Society of Critical Care Medicine recently. So I'm going to keep things very brief and reiterate the highlights of the new Surviving Sepsis Guidelines and reiterate some of the old guidelines that have remained in place. All right, I think the first most important thing for everybody to realize is that sepsis is the most common cause of death in the intensive care unit and the hospital. Even though sepsis accounts for about 15 or 20% of hospital admissions, it accounts for 40% of hospital deaths across the country. 750,000 or 1 million cases of sepsis are admitted to hospitals in the United States, and that number is going up. Sepsis is now the fourth leading cause of death in the US of A. Let's think about some of the common sources of sepsis, okay? Whenever you see somebody with sepsis or you're admitting somebody with sepsis to the hospital, the first place you want to look at is the lung. That is 35% of the cases in the United States. The source of sepsis is pulmonary. That means they have pneumonia. All right. The second most common source of sepsis, if you don't find it in the lung, then go down to the urine, because it's probably in the urinary tract. So look at the urine, look for a UTI or pyelonephritis. What if you don't find it there? Next place I look for is in the gut or gallbladder. Likely to be ischemic bowel, peritonitis, colitis, diverticulitis, or cholecystitis, or pancreatitis. And the last place that you want to look at, if you don't find it in the above, is a skin infection. So roll the patient over, you might have cellulitis, and then miscellaneous sources of sepsis are generally CNS, thorax, meningitis. That's what I would look at. So you got to keep looking for the source of sepsis. The first thing I want to go over again is the pathophysiology of sepsis and severe sepsis. And we have to remember what's going on in a patient with sepsis. When you get attacked by a virus or bacteria, what ends up happening is your whole body gets inflamed. When your body gets inflamed, you start an inflammatory process, right? We call that SIRS, Systemic Inflammatory Response Syndrome. That has not changed. Okay, that concept physiologically still sticks. Your whole body is dysregulated. That's what they're now calling it. It's a dysregulation of all your organ systems that become inflamed. You start clotting up your blood vessels because the platelets stick together, and once you get these clots, they don't break down. So you get sludging of your microcirculation, and you often see things like mottling, right? You've all seen that. Patients are cold, they're mottled, they're febrile, they get altered, their CNS function, they get lethargic, they get delirium. Why? Because the brain is not getting the circulation, the kidney doesn't get the circulation, their extremities are cold and mottled, okay? That's microvascular dysfunction and clogging up your circulation. You get these thrombosis. Now, one of the things we often forget, and I have to keep reminding people, is that whatever fluids we give people, they're going to leak out because you have capillary leak syndrome. So your endothelium inside your capillaries is now stretched to the point that you have like a sieve-like picture. All the fluids that we give, including the albumin that they have inside their body, very quickly leaks out. So serum albumin on me, after a day of sepsis, is going to be 2.5. It's not that I'm malnourished, I didn't eat my steak and fish every day. That's not it. I could be very healthy, but my serum albumin will drop. When you don't have albumin inside your blood, you're going to develop leak. Okay, so this is what happens. The endothelium in your body cannot hold on to the fluids, including protein, and it leaks out. So when you see in the ICU these patients after 4 liters of fluid, they're all puffy, and the family asks you, oh, my dad didn't look like that. What have you done to him? How come his arms and legs are all puffy? Well, it's because we have leaky capillary syndrome. And the place that this is most detrimental let's not forget, is where? In the lungs. I don't care if the arms and legs are puffy. Who cares, right? The family does. But what I care about as a critical care doctor is that the lungs are getting wet. All right? And they are going to get wet. There is no way to stop it. So we have to be very cautious how much fluid we give. And that's the whole point of this talk. Because these organs, not just the lungs and kidneys, these organs get hypoxemic. Okay? Oxygen does not traverse fluid, all right? So then you start getting multiple organ failure, and that's what you die from in septic shock. Your organs are failing, all right? Especially kidneys, we worry about that. So let me review sepsis pathophysiology. Let's remember, in the ICU, when we hook up a patient to a SWAN, to a non-invasive cardiac output monitor, what do we expect to see? We expect to see that the systemic vascular resistance is very low. Why? Because they're vasodilated. It's what we used to call warm shock, right? The patient is warm, the blood vessels are dilated, the artery, the veins are dilated, you get capillary leak, they get volume depleted, and usually the cardiac output is elevated. So you get a high cardiac output, you get a low systemic vascular resistance, okay? And sometimes, if the patient has a bad heart, the cardiac output or cardiac index is low. Whenever you see a low cardiac index in a septic shock patient, you have to consider that the patient has previous cardiac disease. Maybe they had coronary artery disease, maybe they had a previous MI, or some patients, just because of the sepsis, for 1 week, will have decreased ejection fraction. The one thing that people don't understand or recognize is that the majority of your blood volume in your circulation is actually on the venous side. 75% of our blood volume, which is about 4 liters, is actually in our veins. The rest of the blood is in the organs, the brain, the kidney, the heart, and about 10% is in the arteries. So when we're worrying about arterial blood pressure, then we're manipulating people's blood pressure with pressors. We often don't realize that actually what we're trying to do is play with the venous volume, the venous blood. And this has become very clear in the last few years. Even I never really thought about it until a couple of years ago. All right, so this is new to me too. So let's talk about a typical patient that comes to our ER, right? Remember, most of our patients with sepsis are going to have pneumonia. So let's talk about the school teacher who is 62 years old. She weighs 80 kilograms. She comes to the ER with fever and cough. It's the winter season. It's the flu season, very typical. We're just getting over it. And she turns out to have influenza A. Her chest x-ray shows she has a dense right lower lobe infiltrate. So this is a community-acquired pneumonia in somebody who's at home. Not coming in from a nursing home, just bread and butter pneumonia. Okay, what should we do with her? Okay, the first thing is you want to take care of the cultures and start her on antibiotics. It turns out of all the early goal-directed therapy bundle, or the sepsis bundle if you like, the most effective intervention that saves lives is actually the antibiotic, not the fluids. Okay, I know we jump all over everybody, but don't forget, the number one, if I get sick, I want you to worry about the antibiotic, number one, then worry about the fluids, all right? We want to get that antibiotic in the patient within an hour. Okay, get this patient some Resuscitation. You can figure out what the other antibiotics will be by talking to the intensivist, etc., ID doctor. Then the patient with the flu, I would still go with Resuscitation, azithromycin. You might want to add Vanco because it could be a staph pneumonia, and then the Tamiflu. But don't forget to, and if you're worried what antibiotic to give, you can't go wrong with just starting somebody on Resuscitation or ceftriaxone. Because if it's a UTI, if it's gallbladder, if it's bowel, if it's CNS, 2 grams of Resuscitation will get you going. No matter what's wrong with you. All right. If you're allergic to cephalosporins, then we can discuss that. So let's look at this lady. She's got a white cell count when it comes back 17,000. She's got 20% band, so anything more than 10 is bad. Her electrolytes show that she has an anion gap acidosis. Her anion gap is 20. So right off the bat, I'm thinking, oh, it's lactic acid, right? She's septic, she's got a gap acidosis, her creatinine, BUN are elevated, so she's a little dry, let's give her some fluids. And lactic acid comes back at 4.4. When you do cultures and when you examine her in the ER, her mean arterial pressure is 68. Not bad. Our goal is 65. As long as mean arterial pressure is over 65, I feel comfortable, right? The heart rate is 100. She's breathing at 30 times. Now the question that often comes up, people always say, is this septic shock or is this severe sepsis? The blood pressure, the MAP is over 65. Okay, so this does not qualify for septic shock on the basis of blood pressure, but it does on the basis of a lactate of over 4. I want to say that again. Even if my blood pressure, mean arterial pressure is 80, 90, it doesn't matter. Just the lactate, one factor by itself, given that you found an infection in this patient, makes this septic shock. This is septic shock, all right? So let's talk about it. How are we going to manage this patient? We're going to start this patient on 30 cc's per kilo of saline or ringers. I prefer ringers, but most of the doctors are still using saline. All right, I'm not going to go into it's kind of complicated. I'm not going to go into it too much. But why am I giving 30 cc's of saline? Because this is septic shock. If it were severe sepsis, I would not give fluids. I'm going to say that again. For severe sepsis, you're not going to give fluids. For septic shock, you're going to give fluids. All right? That is the recommendation in the surviving sepsis guideline. So after the nurse runs in 30 cc's per kilo, wide open, should have taken, maybe an hour or so. The blood pressure is 92 over 50, and her mean arterial blood pressure now is 65. So remember, our definition of septic shock is a MAP less than 65. So now we have two factors that qualify for this patient to be in septic shock, correct? We now have a MAP of under 65 after fluid resuscitation, and we have a lactate of 4.4. We admit this patient where? Intensive care unit, not to the floor. Next question that I want the ER to figure out, and this is really the nurses and the ER doctor's job when I come down for a consult, is what is time 0? Because the sepsis bundle starts at time 0. So the answer to this question is 5 p.m. Why? Because the patient first met criteria for septic shock with a lactate. So it's not 5:45, it is 5 p.m. Okay, so the nurses should know that. Whichever episode occurs first, the hypotension or the lactate over 4, is when the ER then communicates to the rest of the team. The 6-hour sepsis bundle started at 5 p.m. Now I have 6 hours. That means I have until 11 p.m. as our medical center to complete the whole bundle. Remember, it's all or none measurement. That means that if you miss one component of it, you fail. I'm going to say that again. We miss one component of the 6-hour sepsis bundle, the whole team is penalized. 5 out of 6 does not count. All right? So, first of all, let me go through the definition. Let's make this completely clear. What is our definition? Sepsis is defined as you have 2 out of the 4 SIRS criteria. You got attacked by a virus or a bacteria. You have an infection on board. Your body became inflamed systemically. We call that SIRS. These are the criteria. You have fever, hypothermia, tachycardia, respiration rate over 20, white cell count over 12, or more than 12% bands, or more than 120 blood sugar in a non-diabetic. Those are SIRS criteria. If 2 out of these 5 are present and you have a focus of infection, then we call it sepsis. It's not severe sepsis, it's sepsis. A pneumonia patient with just this and a chest x-ray, you admit to the floor. Your diagnosis is sepsis. It is severe sepsis when you see any of these. This is severe sepsis. One organ has failed. The way we measure organ failure, you look at blood pressure. If the blood pressure was less than 65 MAP, you gave 30 cc's per kilo, but now my MAP is 75. I go to the floor. That's not septic shock. I responded to the fluid bolus. It's severe sepsis. If my creatinine has risen acutely to above 2, I have normal renal function, now my creatinine is 2 or above, or I'm not making urine, my urine output has dropped, that's one organ failure. You are in respiratory failure. If you're on 100% oxygen, your PO2 divided by 1, which is 100% oxygen, is less than 300, so get a blood gas in pneumonia. Work out a PF ratio. If my platelet has dropped less to 100,000, my INR has gone up to greater than 1.5 and I'm not on warfarin. If I'm altered, I'm lethargic, I have neurological symptoms, or my bilirubin is acutely gone over 2, or my lactate is over 2. This is severe sepsis. This is not septic shock. This is severe sepsis. This does not come to the ICU. This goes to the floor. Okay, now about 10 or 20% of these, when they go to the floor in the next 24 hours, will turn into septic shock. So it doesn't mean we forget them, because in spite of the antibiotics, they will deteriorate and you call a rapid response to the floor and then transfer them to the ICU. But they don't necessarily need to go to the ICU. This has been looked at over and over again, that the mortality is no higher if you admit these patients to the floor. Okay? This is where doctors get confused constantly. The difference between sepsis, severe sepsis, and septic shock. All right? One way that the national, international intensive care people said is that, you know what, the severe sepsis and sepsis criteria and SIRS criteria are very loose, so let's use the QSOFA, which is the Sepsis Organ Failure Assessment Score, as an identification as better than SIRS to identify patients who are turning septic on the floor. Right? So if you have altered mental status, confusion, lethargy, they're not responding, okay, the respiration rate is over 22, or they have a blood pressure of less than 65 MAP, systolic less than 100, any 2 out of these is a positive for a sepsis alert rapid response team. Because the chances are that they are septic. This is a very good way of screening. Which is better, SIRS criteria or QSOFA? I think it doesn't really matter. I think whichever you use to call doctors to the bedside to evaluate the patient is very important, okay? So going back to sepsis, severe sepsis, and septic shock. There are only 2 criteria for septic shock. I wish people would just remember this. There are only 2 criteria. Sometimes you have both, and sometimes you have 1 out of 2. But 1 out of 2 qualifies. So hypotension after the fluid bolus, a MAP less than 65 or a systolic less than 90 after your 30 cc's, that's septic shock. It's not septic shock until you've given the fluid. Okay, and that's when you start vasopressors, norepinephrine. Or even if my blood pressure is okay and my MAP is over 65, but the lab calls you and say, oh, patient's lactate is over 4. Boom, that's septic shock. This is where we forget. A lactate over 4 by itself qualifies you for septic shock, regardless of the blood pressure, regardless of the blood pressure. The time that this is, either one of these is first identified is time 0. And that needs to be communicated to the rest of your relay team. So your relay team, the baton gets handed over to the ICU nurse, to the ICU doctor, to the hospitalist, is we identified time 0 was 5 p.m. Without that, we are lost. And we will fail as a team. Okay, so we got to figure that out. We can put it on the chart, we can put it on the bedside. Somehow or another, we have that green form that we have. I think the nurses fill that out in the ER, and it works very well. Okay, now the rest of the team is on board. What does the team do? Make sure that we've already done 2 sets of blood cultures in the ER. Make sure we start vasopressors peripherally. It's okay, you don't need a central line. Okay, if the blood pressure doesn't come up with the fluid bolus. Okay, start the antibiotic within 1 hour. This month's critical care medicine, there was a meta-analysis on early goal-directed therapy. Out of all the interventions that we do, it's not the fluid that saves lives. It's actually the antibiotic. So if there's anything we can do for our patients to save lives beyond all the other components, the norepinephrine, the lactate measurement, get the antibiotic. Now I've talked, and we can talk to pharmacy about making sure that at least we have Recephin in the ER. At least we have Recephin on the floors, because at nighttime this could be an issue. All right, so start 2 grams. So the new sepsis guidelines in 27 have changed the antibiotic goal to 1 hour instead of 3 hours. And they have recommended this as an aspirational goal. But when you look at the data, I don't even agree with this. I think it should be a mandatory goal. It should not. If I'm the patient, I want it to be mandatory. I don't want it, because then the message that you're giving is that it's optional, right? I don't think we should have that kind of culture. I think the culture we should have is there's compelling data that every 1 hour delay in administering antibiotics increases my mortality by 8%. So I'm thinking of the patient in the bed. If that's me, if that's my family, 8% is a lot. That means if you give it to me in 3 hours, you've increased my mortality 16%. That's awful. That's awful. Okay? Again, reiterated in next month's critical care medicine. I got an early copy. All right? So, what are we going to do? We can look back at early goal-directed therapy that Manny Rivers 15 years ago said, this is what you're supposed to do. If your patient has hypotension and lactic acidosis, start early goal-directed therapy, give tons of fluid, put in a central line, right? You all remember that. Every patient in the ER doctors were compelled to put in a central line, measure the CVP in the ICU, push the CVP up to 15 on intubated patients, start dobutamine, transfuse patients to a hemoglobin of greater than 10. This is old hat. Okay, not only is this old hat, but it's turned out, yes, Manny Rivers' early goal-directed therapy probably saved a lot of lives, but not by the interventions. I think we saved lives because he brought to the ER recognized sepsis. That's what he really brought. Stop putting these patients in the back while you take care of the code blue and the gunshot wound. Start looking at sepsis, because that's a killer. I think that by itself changed our culture. Are we transfusing people to 10 grams? No, we're not. 7 grams is adequate. You don't need to transfuse. Are we using dobutamine and SCVO2 and CVP? No. In fact, in the recent literature, they found that a CVP greater than 8 does not predict fluid responsiveness. It causes lung edema and ARDS, and the #1 predictor of renal failure in septic shock is a CVP over 8. I will say that again. People are shocked. They don't believe this. There have been 3 separate studies that have shown that if you drive the CVP above 8, you're going to lead to increased injury to your kidneys. Why? Because they get edematous. You get lung edema, you get renal edema, and the cumulative fluid balance, the total amount of fluid that we give in the first 48 to 72 hours in the ICU is the best predictor of mortality. What it's saying is that the more fluid I end up giving, the higher my risk of dying. My risk of dying goes up 10% for every extra liter of fluid I've given. Okay, so now by delaying antibiotics by 2 hours and by giving extra fluid, every 1 liter increases my mortality by 10%. So I could easily increase my patient's mortality by 30% by delaying antibiotics for 2 hours and giving extra fluid when it's not warranted. So the difficult situation is, when am I warranted to give more fluids? According to the new sepsis guidelines, EGD cannot now be recommended from the evidence that we have. So what I'm saying here is, if I give too little fluid, patient will die. If I give too much fluid, I'm going to get renal failure, pulmonary edema, okay, and my mortality goes up. So what is the best amount of fluid? That is the holy grail. That's the $64,000 question. And do I just eyeball it, just wing it, or do I scientifically do it? Okay, that's been the challenge. Scientifically, we were doing it with CVP. As I've shown you, CVP is not just outdated, it's actually the wrong number. And if you use CVP to guide fluids, you will increase the mortality, not decrease it. All right? So, fundamentally, the only reason to give fluids is to increase my perfusion to my organs, correct? We all agree with that? And the only way I'm going to increase my perfusion to my organs is to increase my cardiac output. So the question is, how do I know how my patient's heart is doing? And how do I know that my heart is pumping as much fluid as it can, as much blood as it can, and if I overshoot, my heart cannot pump any more blood to my toes, to my bowel, to my kidney, and all I'm going to do is accumulate edema. Correct? Does that make sense? So the objective is for our cardiac output to become, okay, on the plateau part of the Frank-Starling curve, which we all learned in school. But how easy is this to do technically? Do we have the technology to do it? So let's review the technology that we do use today to achieve that. Okay, and this is a nice review in JAMA, just last year in February, where they looked at 50 studies to see if, when I give you a fluid bolus, is my cardiac output and my perfusion improving? All right, and which is the best technology? Well, physical examination is worthless. The likelihood that my physical examination, looking at your toes, your feet, your knees, is going to help me determine whether you need more fluids is about 1 to 1. That means a flip of the coin. Not that useful. Using CVP to drive it up to greater than 8 is actually negative. That means it has worse outcomes. So that's the last thing you want to use, is a CVP. Using an echocardiogram, okay, which is the doctor getting an echo machine with the right probe to look at the heart and look at the IVC collapsing. If my IVC is collapsing, it tells me that the patient needs fluids. Well, how good is that rule? That rule is actually pretty good. It increases my chances that I'm correct 2 to 3-fold. But the intervention that increases my likelihood that I am correct that the patient needs fluids is what we call the passive leg raise test. So many of you may not have heard of this concept, so let's review this. Okay, let me just kind of first of all review why we don't want to give too much fluid. If I am on the Starling curve and the plateau, and everybody's at a different plateau depending on if you have high blood pressure, coronary artery disease, how old you are, somebody can tolerate more fluids. An older person who has hypertension or has coronary artery disease, has a stiff ventricle, may not tolerate more fluids. If I give that individual, depending on where they are, too much fluids, I'm going to flood their lungs. Then they end up on the ventilator, and that could drive up their mortality, right? So what do? What is a passive leg raise test? It might be a new concept to many, but this actually has been around for about 8 years. Okay, started in Europe, where they did studies to say that, you remember in the old days we used to put people in Trendelenburg position, right? When we put their head down, they aspirate, okay, and their belly goes into the chest. So don't do that. That's not a good idea. But what we can do is just elevate the legs. When we elevate the legs without putting them in Trendelenburg position, you are infusing about 300 cc's of blood from your veins. Remember I told you that 75% of your blood is in the veins. Well, we can recruit your own blood by just lifting the legs. When we lift your legs, 300 cc's from your legs get into the venous circulation, which will go to the right ventricle, through the lungs to the left ventricle. When it gets to the left ventricle increases its cardiac output, what we call the stroke volume. If your stroke volume goes up by more than 10%, that means it's okay to give you more fluids. That means you're still fluid responsive. If you're not fluid responsive, don't give any more fluids. Stop. All right? So how do we actually measure it? This has been the big controversy. Technologically, do we have equipment to raise your legs and measure with some kind of technology that says, oh wow, your cardiac output, your stroke volume went up by 10%. So what we are doing, and there may be false negatives, okay, the chances that you're going to have a false negative is about 10 to 15%. Why? If you have a big belly with ascites, with liver disease, a bleed in your belly, that blood from your legs is never going to see the heart. So then you might get a false negative. Then you need an echo. But this is the best technology. Passive leg raise test today is the way we manage fluid resuscitation in circulatory shock. Okay, even in a bleed. All right. So how do we measure to see when I raise your bed, did you actually pump out more blood? All right. The way we do it is with this machine. This is the NICOM. All right. And what it does, it measures, it's a dynamic assessment. That means that it changes with time immediately what you're seeing with physiological response. This is dynamic assessment. The way we do it is, and we hope that the ER eventually get this machine, all right, sometime in the future, that they are able to do this in the ER. What it is you put leads in the shoulders and on the hips. And there are two leads, and what it does, this is bioreactance. So it's like physics of the phase shift between diastole and systole, and that measures the cardiac index. All right, and then you get a readout on your monitor, which will tell you that if the stroke volume went up the Starling curve by more than 10%, you can continue to give fluids. And you decide how much you want to give with each bolus after the passive leg raise test is up to you. Generally, you want to give at least 250. But if the patient is very fluid responsive, very dry, I might want to give 500 right off the bat. So if my SVI goes up by 12%, I might want to just give 250. But if my SVI goes up by 30%, I might want to give the whole 500 because you want to get things in fast, right? So when the patients do not increase their stroke volume with passive leg raise or with a fluid bolus by 10% or more, do not give any more fluids. The patient is tanked up. Now you need to use drugs to figure out how to manage the shock. Correct? So with me so far? Now remember that capillary leak syndrome will lose fluid again. In about 30 to 60 minutes, you have to pay attention to this waveform, which we will train all the nurses and doctors. If this is sliding down and the patient is still in shock, then at that point you might want to re-bolus them. All right? So constantly pay attention to that. So this is an example of what you will see on the screen. You will see whether the patient is fluid responsive or not. If this number rises with fluid bolus or with passive leg raise by 10% or more, they're fluid responsive. There's no other way to do this. This is the safest and best way to do it. This is dynamic, constant assessment of the patient. But let's say that the patient is not fluid responsive. They have already reached the Starling curve at the plateau. Are we done with this machine? Toss it out? No, because this machine is basically a hemodynamic monitor. It will give me the cardiac index and it will give me the vascular resistance. Remember what I said in my first slide. The patient with septic shock is going to have vasodilated shock. That means the vascular resistance should be very low. All right? And why do we use norepinephrine? Because norepinephrine cranks up the vascular resistance. So it increases the blood pressure by clamping down those veins more than the arteries actually. It's also a venoconstrictor. Norepinephrine is a venoconstrictor and an arterial vasoconstrictor. Bring my blood pressure up. In this situation, what we're seeing is that the cardiac index is low. What type of cardiac index do you typically see in a septic patient? 4 liters, 5 liters, okay? At least 2.8. If you see a cardiac index of less than 2.8, which happens in about 25% of cases, your heart, even though it's tanked up by Starling's curve, doesn't have the oomph, doesn't have the horsepower. And so what do we use to give the left ventricle more horsepower, more contractility? An inotrope. What is the good inotrope? In the surviving sepsis guideline, they recommend dobutamine. Okay? So I'm looking at this patient who actually is not vasodilated because the TPRI number should be between 1800 and 2400 is normal. Okay? If you go over 2400 on the total peripheral vascular resistance index, you're actually clamping the blood vessels too tight. And if you clamp too tight, the cardiac index will drop, right? Because the heart can't pump through a tight hose. Now what I want to do is I actually want to vasodilate the blood vessels and use an inotrope to get the heart to pump. So here I would not increase, do not increase the norepinephrine, even if the blood pressure is 60 MAP. Because if you increase the norepinephrine on this patient, you're actually going to drop the cardiac index. So I might leave the norepinephrine on, okay, but I'm going to add an inotrope. So now I have a patient on norepinephrine and 2 mics of dobutamine. Start very low, don't start high, okay, 1 or 2 mics. And then if the blood pressure comes up, drop the norepinephrine. So now I have 2 drugs. They're doing 2 totally different things. The norepinephrine is clamping my blood vessels, but the dobutamine is saying my heart is weak. Let me get a little more pump. Okay? So as you can see, the NICOM gives me 3 pieces of data. Tells me if I need more fluid, tells me if I'm okay with the norepinephrine, go up on the norepinephrine, but if my blood vessels are too tight, I might want to drop the norepinephrine, and it tells me if I have a pump function problem. Okay? So that's the technology that we use, and this meets the surviving sepsis guideline. What we're doing here absolutely 100% meets the guidelines. Alright? What is the other thing that the guidelines say? If we're not going to use CVP and mixed venous O2, which is in the surviving sepsis guideline, why? Because we have assessed the data and we feel that is not best for our patients. So doing the NICOM and passive leg raise alone doesn't meet the criteria. So the second part of the criteria that the surviving sepsis guideline allows you to do is to use an echo machine to assess whether the patient is fluid responsive or not. So the ER doctors have to learn this. The intensivists have to learn this. When you bring the patient to the ICU, I have to have an echo machine, and I have to use it. It's mandatory, it's not an option. This complements my other data. Why? Because what I'm going to do is I'm going to look at the right ventricle, I'm going to look at the left ventricle. Do I have pericardial effusion? Am I tanked up? The best way to really see if my patient is tanked up and is responding to fluid is actually a very simple test, which we can teach the ER doctors in a matter of 15 minutes, which is to put the probe right here under the subxiphoid subcostal. It has to be a special cardiac probe. Then what we do is we look at the IVC. I constantly show in the ICU, so if you want to come up, if any of the nurses want to come up, because I constantly show the ICU nurses what I'm doing. What I'm doing is I'm putting the probe above the inferior vena cava. Then what I do is I measure the inferior vena cava from the right atrium, where the IVC goes into. I move out to where the liver hepatic vein enters the IVC, and I measure the diameter of the IVC, just caudal, just prior to the hepatic vein entering the IVC. So I put my probe there, I put a line across there, I put the patient on M mode to actually measure the diameter. When the patient is breathing spontaneously, the IVC will collapse because you're sucking blood into the heart. If the IVC collapses by more than 50%, the patient probably is still volume depleted. So you measure the IVC before they breathe in. Let's say it's 2 centimeters, 20 millimeters. If it collapses down to 8 millimeters, that's a collapse of greater than 50%. That's a very good test. It's not perfect. Nothing is perfect, but this is very good. All right? So the ER doctors have to do this. The intensivists have to do this. So we have to make sure that the charge nurses encourage the intensivists to complete this. And guess what? Nurses documenting this doesn't count. I'm going to say that again. The nurses document what I did, what the NICOM showed, counts for 0. So if there are physicians listening to this tape, please understand, we have to document. The ER doctors and the intensivists have to document, because CMS is not going to look at nursing records. They don't look at it. All right? Now, what we found in critical care medicine recently, there's been debate, and many doctors argue with me about this. What they found is that when the IVC collapses by more than 50%, which is what the Surviving Sepsis Guideline says, you are about 85 to 90% accurate that that patient will benefit from fluids. Generally, if the IVC is greater than 20 millimeters or 2 centimeters, okay, and it doesn't collapse, okay, you are tanked. I found that to be almost 100% accurate, okay, because it jives with my NICOM. All right, so that's basically it. This is where I measure it. I pull up the M mode. I measure it here, write it down, and this is what I document. Okay, I document we're not going to do CVP. It's completely discouraged today in 2017. We're not going to measure the SCVO2. No data to back that up. But we are going to do a passive leg raise test, okay, and we're going to do an ultrasound. And I know the ER is trying to get the probe to get the echo, and I will be happy to come and show the ER doctors how to do this. Next time you have a septic shock patient, I'll be happy to demonstrate. All right? Failing doing the technological scientific approach to septic shock, the CMS core measure will allow the doctors just to document a focused exam. As I've shown you, a physical exam likelihood to predict or guess, basically, we're just guessing, that there will be fluid responsive or not is 50-50. Okay, nobody can be 100% sure. Okay, what do we document in our physical? Again, nurses can't do this, it's the doctor. The doctor has to document mental status, heart sounds, rails, chest examination, capillary refill on their fingers or toes, pulses, radial pulses, dorsalis pedis pulses, posterior tibial pulses, skin color, modeling, and you're done. In the 2017 CMS core measure, if I as a doctor do not document this, I as a hospitalist do not document this, all I have to say in my physical exam under the quality parameter is that I performed the sepsis focused exam, and they will forgive you. If I miss any of these components, I should put in the temperature, heart rate, respiration rate, blood pressure, a physical exam on my admission H&P. And at the bottom, I encourage the physicians just to write sepsis-focused exam done. If the ER doctor does it, if the hospitalist does it, if the intensivist does it, we will be in a very sweet spot. Okay? So if everybody does it, the chances that we're going to be non-compliant are pretty zero. What am I saying? Failing the focused exam. If I can't do this at night because I don't have a hospitalist or ER doctor who can do IVC collapse. I do have nurses who can do the PLR, so still do it. But 1 out of 2 doesn't count. So what will give you a passing grade is to always as a fallback, do a focused exam. After that, CMS doesn't care. Okay, they don't care. You will pass if you just write focused exam done. We're not going to put in a central line on everybody, okay? And then the only other thing that we have to do as doctors and nurses is to make sure that we're tracking lactates every 3 to 4 hours. If your lactate is over 2, you have to get a second lactate. If your lactate is over 4, you have to get a second lactate. I think the lab automatically triggers it, but we have to make sure that the nurses draw it, okay? And if the nurses don't have an order for it, go ahead and do it and just put in an order, okay? So obviously the computer is not always helpful, right? And generally I expect the lactate to fall by 20%. If my lactate is rising, my patient's gonna die. If my lactate is coming down by 20%, we're good. Okay? One last thing I want to mention, and this is particularly pertinent to the ICU nurses. Okay? Fluids should be administered with the same caution that is used with any intravenous drug. Choose the type, dose, indications, and contraindications. I know I have to train my daughters also to understand this. The cumulative dose of resuscitation and maintenance fluids, okay, increases your chances of dying. Maintenance fluids do not improve your hemodynamics at all, 0. So stop thinking that keeping a maintenance drip is going to increase my urine output. There's never been any data on that. Maintenance fluids do not increase my blood pressure, do not reduce my heart rate. That's a myth that has been perpetrated for the 35 years I've been a doctor. Okay, we now have to extract that from nursing school, medical school, and our daily practice. Stop using maintenance fluids. It kills people when you're in shock. If I'm dehydrated from diarrhea and DKA, I'm not talking about that. This is specifically in septic shock, okay, or even with cardiogenic shock and hemorrhagic shock, all right? And then the third part about fluid resuscitation is consider albumin. So that's in the new sepsis guideline. After 2 to 3 liters of saline or ringers, I use albumin. How much? 25 to 50 grams. Let me finally straighten out some facts and fiction about fluid. All right? What are the hemodynamics of fluid bolus? Okay, there is no persistent hemodynamic benefit of fluid bolus. Please spread the word. All right? There has been a review recently, a meta-analysis on if I gave a fluid bolus of 500 or 1,000, okay, how much does it increase my MAP by? 7 millimeters. Okay? How much does it decrease my heart rate by? 2. How much does my cardiac index go up for? 30 minutes. Okay? And by the way, nurses, when we give a bolus of 500 cc's of saline, when you call me for a low urine output, fluid boluses do not increase my urine by 1 drop. Okay, I know that by policy nurses have to call a doctor for low urine output, but if the answer that you're going to get from the other end is give a liter of saline, you just increase that patient's mortality by 10%. By 10%. So can we stop this compulsion of calling hospitalists for low urine output? Please. Can we stop this compulsion of continuing maintenance fluids? When I leave the ICU, the nurses often call the hospitalist because they think Dr. Habib is a dingbat. Okay, he forgot to order maintenance. So as soon at 6:01 p.m., as soon as I leave, they'll page the hospitalist and get an order for saline to be run at 200 an hour. Well, when I come back in the morning, you just gave 2 liters of fluid and increased my patient's mortality by 20%.
You're speaking only in terms of septic shock?
Septic shock. Of course, with DKA, you're going to give fluids, right? Diarrhea. Hyperchloremia should be avoided, so I don't use saline, I use ringers. Albumin meta-analysis shows that your mortality goes down by about 20% by adding albumin to saline or ringers. Avoid Haspan and don't use bicarb. Okay, this is the summary of the sepsis guideline from 2016. We recommend that resuscitation for sepsis-induced hypoperfusion, at least 30 cc's of crystalloid fluid be given in the first 3 hours. This is being challenged. This is a strong recommendation. Quality of evidence is low. But since the CMS core measure mandates this, we're going to do it. Okay? If you don't want to give it because the patient has heart failure, they've had a big stroke in the brain, you're going to cause cerebral edema, please make your doctors write it. Renal failure is not a contraindication to 30 cc's. Okay? We recommend that following the initial resuscitation, additional fluid should be guided by frequent reassessment of hemodynamic status, and we're using dynamic monitor, not CVP. All right? Reassessment should include a thorough clinical examination and available physiological variables: heart rate, blood pressure, O2 sat, respiration rate, temperature. What's the data for this? 0. All right? We further recommend hemodynamic assessment, such as assessing cardiac function to determine the type of shock, and clinical examination does not lead to a clear diagnosis. So what they're saying is that if you're still in shock after the 30 cc's, you need an echo, because it could be cardiac. Okay, I could have a pulmonary embolism. I could have a pericardial effusion. All right? Can you just I'll call him back. We suggest that dynamic over static variables are used. What does that mean? Static with CVP, Swan-Ganz, wedge pressures, don't do that. They're not of value. Dynamic is passive leg raise test and stroke volume measurement. That is called dynamic variable hemodynamics, and that's what we're doing. Okay? And that's pretty much it. The last thing, okay, in this day and age, today in 27 in surviving sepsis, this is what your ICU ER should look like with a NICOM. Okay? Yes, there are surviving sepsis guidelines, but like John Kennedy says, too often we enjoy the comfort of opinion without the discomfort of thought. And today, this is so important that we think for ourselves, regardless of what the guidelines say. Okay, the guidelines are guidelines, but we have to use our brain. Okay? Thank you.
Any questions, Q&A? Questions? No?
This is a big change, right? This is a big changes. Big changes.
Do you like what you're hearing?
We like what we're hearing.
So I know-
I had a patient yesterday
That could have, would have, huh?
that, yeah.
Could have, potential would have. This is the actual machine, and so we are getting one for Edie. I've been trying to engage Ukiah, Willits, and Clear Lake. We finally got Clear Lake to kind of start thinking about it. So hopefully they'll get the machine. So there's really 2 machines you guys need to get. That's the Echo and the Cheetah. You'll have one machine. And essentially what we're paying for are the electrodes, which aren't that expensive. And they last about, the rep will come, the nursing clinical educator will come, and they'll in-service every single one of you guys. But it's practice, practice, practice for the ICU nurses, I've noticed. If you apply the electrodes, they last for 48 hours. So if you guys apply them, we can use them. If Clear Lake applies them, we can use them. So don't take them off. The other thing, the take-home messages that I took away from the education that we had received last year was, that's number 1. Number 2, you can apply this on every type of patient, any type of patient that is receiving a bolus. Really, it's that user-friendly. It is not internal, so it's not a swan. You don't need a swan. It's external, and we get that, and we get the numbers are, but it gives you data that you can use. So say it's an open heart patient. They get mannitol A6 during OR. We slam them with fluid all night. That might be a little too much. What if they're at the top of the Starling curve, right? They can't take any more at that moment in time. Maybe they need a pressor. Maybe they need something else. It's the same concept. We had our first case that we thought to use this on was not sepsis. It was actually a dialysis patient who at the 3rd hour started crumping into the 70s. And so the physicians were debating, the intensivist and the nephrologists were debating whether or not to give fluid. And Linda Hammonds went to grab the machine, first patient we ever put it on, And she measured it, and it was only 2.9%, not the 10. End of story. There's your answer. The patient was probably not going to be able to handle the fluid. So we started levo for about an hour or two, got the patient off dialysis normally, weaned off the levo, we're done. And so the other take-home message from the educator is just that if we throw patients into acute renal injury, all the patients that come from, that we receive, they can eventually become permanent dialysis patients, and that's, I think, kind of where we're all headed to. So if we can avoid giving them too much. So feel free to use this on every patient that comes in through the ED. For sure the sepsis patients, but any other one that you're giving blood or fluid to. GI bleed, anybody, and just go, hey doc, this is the data it's giving me. Leave the electrodes on, right, and then transfer the patient with the electrodes. Then take your machine back, disinfect it, and use it on the next one. You can also detach it, take it on the next one. There is a bank of memory of patients that you can keep on here. So say we had advocated for 4 machines. We have 3 machines. One is our training module. You guys will get one, wipe it down, take it to the next machine, but it will remember the previous patient. So you can come back and plug it in again, okay, if you end up keeping the patient past the 4 hours. Let me think, what else? I think that's it. And then, clean it, wipe it down, and then, put it away, that type of thing. Anything else? You have any questions?